conflicts pertinent to this talk. And I really appreciate this fine group for the work they're doing and the presenters today. This is a white background in America. I think both Lin-Manuel Miranda and the Harvard Business School really do believe that in America, immigrants do get the job done. I hope I can share that more today. I have some disclaimers. We're all here to promote new thinking. I think I'm singing to the choir today. This is a very committed group. There's been talk of unconscious and conscious bias, and I hope that nobody, and I don't think this group is engaged in conscious or unconscious denial. I will speak about underrepresented in medicine. I've heard that's actually a newer term instead of underrepresented minorities, and U.S. Latino diversity to some degree. I'm just one person. There's so many dimensions of diversity, and I will not discuss social determinants of health, even though they're really important in all of this. I think it's important to storytell and just to know where I'm coming from. I'm the youngest of a family of 5 boys to an immigrant Mexican father and a mother whose parents were immigrants from Mexico. No education in my father, and high school education in my mother. I went to a predominantly African-American high school and played American football. That's my twin brother and I. I'm married to a Caucasian woman and I have mixed children. So that's the perspective I come from. It's important to know. Everybody's been seeing this in America and abroad. There's been civil unrest in America. This is part of the contextual social milieu. There's issues of border walls, putting up walls and taking them down. Sexual harassment and abuse has brought forth the Me Too movement. We're a sharply divided country in America, and there are hashtags that come about. I look like a surgeon. I am a surgeon también, and also the Be Ethical campaign, which we hope oversees all that. These issues are difficult to discuss, so I think that this group is amazing in putting forth an effort to talk through a lot of this. Years ago, I was asked to give a talk that was somewhat similar, but don't worry, I've made new slides. And Tony Romeo, a shoulder surgeon in the US, said to me, Ron, talk about colorblind and cultural competence. I looked it up and found that colorblind care is care that's rendered without regard to race, and cultural competence is the ability of providers and organizations to effectively deliver healthcare services that meet social, cultural, and linguistic needs of patients. So I said, is this really a thing? I went to the literature and found a couple of papers. And one says Black male patients, and this study was only conducted in men, were significantly more likely to undergo preventative screening tests and agree to a flu shot if they were offered by Black male physicians rather than white male physicians. And in another study, African American and Latino patients who perceive racism in the healthcare system are significantly more likely to prefer physicians of their own race. What about a diverse workforce? These two publications both generally show that improvements on patient-related outcomes are seen in health professionals with culturally and linguistically diverse backgrounds, and language concordance is important. The language concordant doctors and health system interventions seem to promote health, as shown by these two publications. We've been involved in research in our patients and possible disparities. We published in osteoporosis and care of minorities. We published in ACL reconstruction, and we also recently published in shoulder arthroplasty, and we published in several other areas. But as the window closing on race studies, these two publications, Clinical Orthopaedics and Related Research, as well as JAMA, recently have thought through this and think that race captures a lifelong social experience, and residual confounding cannot be eliminated after statistical control for weak proxy measures such as education level or financial status. You know, I gave my own sputum to Ancestry.com, and at some point in the past, this was what my makeup was. You know, I'm Mexican American and have that culture as my background, but this looked like I was a lot of other things, mainly Spanish and you know, indigenous American. But then some years later, then numbers changed, and I was more Spanish and even less indigenous American and even more Italian. I guess that's why I like the Italian food. On to the the idea of a Latino Orthopedic Association. There is one in the U.S. The American Association of Latino Orthopedic Surgeons. I'm a member. It represents not only members of Latino descent, but all orthopedists who treat members of Latino and Hispanic communities. It's gaining in membership and acceptance. It's younger than Gladden and Ruth Jackson, the African American, and the Society for Women Orthopedic Surgeons. Its inception was in 2009. We owe a lot to Ramon Jimenez on the left, and Richard Zaponte, who's recently passed away, on the right. He hired me as my first job out of training before I joined Kaiser Permanente. So this group supports students, tracks young, interested individuals in orthopedics, has an annual luncheon at our Orthopedic Academy meeting, and is attempting to create linkages to other groups in the U.S. and abroad. The American Academy of Orthopedic Surgeons as well is really looking at this, and just some data and numbers for you. Hispanics are close to 60 million, or 18.3% of the U.S. population. In California, where I live, they're 15.5 million, or 39% of the population, and growing. They still continue to be 2% of orthopedic surgeons in the U.S. as of September 2019, and likely less in leadership. The data on the right shows all underrepresented in medicine. This was a January 2021, 12.5 of board of directors. I was recently a board of director and termed off. Cabinet advisory board, council, and committee leadership 8%, 8.67% in others of these. So the numbers are slightly increasing, and these are just the facts. The AAOS board, though, has made a really concerted effort and is working with their diversity advisory board, and you see there. So they have a focused effort, and we're excited to see further changes coming along. So I'm going to share some data and literature with you at the end here that really talks to how we can get things to come along better. And as others have said, some of this may be repetitive. These are recent publications that look at different items to help move people into the roles of orthopedic surgeons from underrepresented in medicine backgrounds. And the very first one looks at letters of recommendation, LORs, and it says that the use of a standardized LOR may reduce gender and race-based bias in the narrative assessment of applicants. What about choosing underrepresented in medicine applicants? It's been seen that the colloquially defined fit, we want to fit our program, can act to reinforce implicit biases and allow prejudicial disqualification of applicants that hinders the needed progress in diversity. However, an understanding of values fit, to fit to the values of your residency program, and to think about culturally adding to the residency, can promote the drive for diversity that others have even pointed out already, that's essential to growth and success of the profession. The idea of mentors and sponsors, underrepresented in medicine faculty ultimately equal underrepresented in medicine residents. From the orthopedic residency program perspective, the greatest perceived barrier to increasing the racial ethnic diversity of residents in their program is lack of underrepresented in medicine faculty. An international perspective like today has been put forth by the Carousel of Presidents and an AOA critical issues look, and they put forth a number of initiatives and ideas in this. And you can see the paltry growth of Hispanics, 1.4 per decade, 1.4% African Americans as well, in terms of underrepresented in medicine. So more work needs to be done. Talking to orthopedic surgery faculty, there's a lack of diverse faculty, and that is shown here. So to address the differences seen in faculty diversity, a concerted effort should be made to recruit and promote a more diverse faculty given similar qualifications and capabilities were proven. And you can see the table that was from this publication shows the small numbers, even though 17.3% of the U.S. Census Hispanic and Latinos comprised 1.8% of faculty in orthopedic training programs. The JBJS recently has come forth in November of 2020 and put forth, and I direct your eyes to the bottom highlighted portion. They're supporting initiatives to increase minority representation in orthopedic surgery programs and academic faculty throughout the U.S. and publish data on these efforts. And they look forward to promote greater diversity within their organization as well. I asked them if I could be an editor. That's kind of a joke. So just recently, as recent as this week, I saw this, and Hispanic groups are really reaching out and saying, what is going on in terms of underrepresented minorities, medical students, and this. So this was a questionnaire just put out this week. So we're still asking the same questions. So we talked about sponsorship earlier. So who lifted me up? My parents, my brothers, my wife, my two children. Who has sponsored me? Dr. Fu, I see, is on this call. He, Italian-Americans sponsored me in medical school. J.P. Warner in my training. Once again, Dr. Fu throughout and further. An Armenian-American was the first to hire me. And I've sponsored females, Asians, and Persians. And I'm continuing to mentor others. And I want to direct your attention to mementor.org. And I think that's important to know. I'm going to end here. Dr. King, as well as others, have thought about this, and we hope that one day we can all be judged by not by the color of our skin, but by the content of our character. And we've heard other thoughts of how there's much more that unites us than divides us. We all have to be together, but we have to understand our differences and find growth among those who don't actually always agree with us. So in conclusion, cultural and language concordance are critical for better patient care. Racial disparity in health outcome studies, I think, are revealing, and I would encourage others to be involved in these questions. Hiring is the holy grail. Diverse and underrepresented in medicine residents are aided by underrepresented in medicine attendings. Mentoring, sponsoring is encouraging at all encouraged at all stages, as others have said, and more work is to be done. Thank you very much.